Hello everyone, in Yayooo Academy, Dr. Yayooo Pharmaceutical Academy for the FGE, Nablets, and Bibit for Canadian Code of Pharmacy. Today I will explain more about the central nervous system, diseases of central nervous system, and drugs for the treatment of central nervous system. Let's start the lecture now. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. Before we start, let's remember about the nervous system. Nervous system, if you remember, we talked about it before in the autonomic nervous system when we talked about the sympathetic and parasympathetic. So we talked about the sympathetic and parasympathetic as autonomic nervous system, which firstly we said that the nervous system is composed of central nervous system and peripheral nervous system. The central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which is like that autonomic nervous system and somatic nervous system. Somatic that is present with the skeletal muscles, and it's for the voluntary movement. But about the autonomic nervous system, it's for the involuntary movement, like the sympathetic and the parasympathetic. So today we will talk about the central nervous system, which is about the brain and the spinal cord. To understand about it, we should to know about what are neurotransmitters in your brain. We can classify the neurotransmitters in the brain into the amino acids neurotransmitters, the biogenic amines, and acetylcholine, and the gases. So the amino acids neurotransmitter, some of them are inhibitory neurotransmitters and some other are excitatory amino acids. So inhibitory amino acid neurotransmitter and excitatory amino acid neurotransmitter. Inhibitory amino acid neurotransmitter like the GABA, gamma amino butyric acid, and the glycine. So the GABA, gamma amino butyric acid, and glycine, these are the inhibitory neurotransmitters. And the excitatory neurotransmitters like glutamate, aspartate, beta-alanine. Glutamate, aspartate, beta-alanine. Let's say that inhibitory neurotransmitters, amino acid neurotransmitters, that like GABA and glycine, we can found these, like the GABA neurotransmitter can bind to the GABA receptor, and this will induce the chloride channel to open. After opening of the chloride channel, this is leading to entrance of the chloride into the cells, and this is leading to the hyperpolarization, which is that inhibitory action of the GABA. Glycine receptor present in the spinal cord, present mainly in the spinal cord. So the GABA can present in the brain, and the GABA is accompanied by opening of the chloride channel and let the chloride enter, and this is leading to hyperpolarization, which means that the inhibitory effect. This inhibitory effect, which is like what? It is sedative, hypnotic, anticonvulsant, anxiolytic. Sedative, hypnotic, anticonvulsant, anxiolytic. And the excitatory neurotransmitter like the glutamate, aspartate, beta-alanine, these amino acid neurotransmitter can bind into the NMDA receptor, which is N-methyl D-aspartate receptor. N-methyl D-aspartate receptor. Okay, and when the glutamate aspartate beta alanine bind into the N-methyl D aspartate receptor, this is letting the sodium channel open, and the sodium will begin to influx, and this is leading to depolarization, which is excitatory effect in the brain, which is opposite to the GABA action. So it will be leading to convulsion, it will be leading to insomnia, it will be leading to an anxiety, which is opposite to the GABA. Okay, that's about the amino acid neurotransmitter that is inhibitory like GABA glycine, which can make sedative, hypnotic, anxiolytic, anticonvulsant, and excitatory like glutamate aspartate beta alanine that act on the N-methyl D aspartate receptor and leading to opening of the sodium channel to let the sodium entrance or influx, that leading to the depolarization, the excitatory effect, which is the convulsion, insomnia, and anxiety. About biogenic amines like the dopamine, epinephrine, serotonin, histamine, all of these can present on the brain as a biogenic amines. Dopamine, epinephrine, serotonin, histamine. And about the acetylcholine present in the brain also, and about the gases, which is like nitric oxide and carbon monoxide, present on the brain also. Let me remember you about when we said before that always the potassium inside the cell, sodium is outside the cell, and also calcium, and also the chloride. So if we need to talk about the normal membrane potential, that the sodium, calcium, and the chloride is out and the potassium inside. When I found any increase in the positive charge inside the cell, this is meaning depolarization. Any decrease, this is meaning repolarization. Like that, when I say sodium influx, so sodium have a positive. So influx, this is increase positive inside. Calcium influx, calcium is positive, and this is increase a positive inside. So increasing the positive inside leading to depolarization, which is increase the potential and make depolarization. But about that, when decreasing the positive inside, like that, the potassium outflux, the sodium outflux, the calcium outflux, this is decrease the positive inside. This is leading to repolarization, which is decrease the potential. And if the chloride, which is a negative ion, influx, this is leading to hyperpolarization, which is severe decrease in the potential. Okay, so it is severe decrease in the potential. Okay. That is about the GABA receptor. When the GABA neurotransmitter act on the GABA receptor, this is leading to influx of the chloride, which mean, if you remember, hyperpolarization, decrease, severe decrease in the potential. And that is make inhibitory effect on the central nervous system, which can give anticonvulsant, anxiolytic, sedative, and hypnotic. Okay, and let's remember from the enzymes, when we talked about enzymes, the receptors, and so on, I talked about allosteric site. Allosteric site, which is that allosteric site can induce the major receptor conformational changes in the major receptor to be able to potentiate the action. So here, the allosteric site is a benzodiazepine receptor. Benzodiazepine receptor at which the benzodiazepine or barbiturates, benzodiazepines, drugs or barbiturates drugs can bind to the benzodiazepine receptor, and this is potentiate the GABA to act. Potentiate GABA action. Okay. But about glutamate aspartate beta-alanine, as I said, it binds to the N-methyl D-aspartate receptor, and this will leading to opening the sodium channel to lead the sodium influx, which increase the potential, make depolarization, which make the excitation in the central nervous system, leading to convulsion, insomnia, and anxiety. Any muscle or neuron or membrane require a change in voltage to give its action, which we call it as increase the voltage depolarization, decrease the voltage repolarization. Very decrease in the voltage or the potential, it is hyperpolarization, and that's again determined through movement of ions through the membrane, the sodium influx, the calcium influx, the potassium influx increase the potential and make depolarization. But potassium outflux, sodium outflux, calcium outflux, this is decrease the voltage or the potential and make repolarization. But about the influx of the chloride channel, the chloride ion in the chloride through the chloride channel, leading to what? Leading to severe decrease in the potential, very, very high decrease in the potential, which can make hyperpolarization. Okay, and here it's the action of the GABA, which is the inhibitory, and the glycine, but this is the action of the glutamate aspartate beta-alanine, which they act on the N-methyl D-aspartate receptor. Let's say about the diseases in the central nervous system. These diseases, I can classify them mainly to about 7 diseases: insomnia, anxiety, epilepsy, depression, schizophrenia, Parkinsonism, Alzheimer. Okay, guys, so insomnia, anxiety, epilepsy, depression, schizophrenia, Parkinson's, and Alzheimer. These are the major diseases of the central nervous system that I will talk about them in details in the next slides. But before we talking about them, this table is very, 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 very important. Why? Because what I will say now, which that you require to understand very well, very, very well, for to understand the whole central nervous system. I will talk about what abnormalities that happen to give, which can cause a disease of these diseases, and how to treat this by opposite or by conversion the cause. Like, for example, when I say insomnia, what can cause insomnia in the brain? Decreasing GABA, decreasing melatonin, increasing epinephrine action on the alpha 1 receptor, and increase histamine. So if you have any drug that makes the opposite, will treat the insomnia, which means decreased GABA is abnormality that can cause insomnia. So if I give drug that GABA agonist or benzodiazepine agonist, which increase the GABA action, this is treat the insomnia. When I say low melatonin leading to insomnia, so you can give in melatonin agonist or melatonin analogs, okay, that increase the melatonin in the brain and decrease the problem and treat the problem of insomnia. That high norepinephrine action on alpha 1 receptor, so I can give an alpha 1 blocker. That high histamine, so I can give antihistaminic drugs, and so on. When I talk about anxiety that can cause by the decreasing in the GABA action or decreasing in the serotonin. So if you're giving GABA agonist or benzodiazepine agonist or given serotonergic agonist, this is increase the treatment or curement of the anxiety, make an anxiolytic action. When I talk about the epilepsy, epilepsy is that decrease in the GABA or increase in the depolarization by increasing the calcium and the sodium influx. So I can give in GABA and the benzodiazepine agonist. I can give in N-methyl aspartate receptor antagonist. I can give in sodium or calcium channel blockers. About the depression, it's due to that low in the norepinephrine in the brain or low of the serotonin. So if you increase norepinephrine, increase serotonin, this is treating the depression. About schizophrenia, that is increase in the dopamine or increase in the serotonin leading to schizophrenia. So if you give dopaminergic blockers or serotonergic blockers or the D4 agonist, this is leading to the treatment of schizophrenia. Why D4 agonist, guys? Because D4 agonist is used for negative feedback about the dopamine release in the brain, like that alpha 2 receptor in the norepinephrine. When the alpha 2 have agonist effect, this is decreasing the release of norepinephrine and epinephrine. It's the same if you given dopaminergic 4 agonist, this is decrease the release of the dopamine from the neuron. In the Parkinson's, guys, low dopamine or high acetylcholine, low dopamine and high acetylcholine leading to Parkinson's can cause Parkinson's. So if you're given dopaminergic 2 agonist or anticholinergic drugs, I can treating the Parkinson's. But let's say something, guys, here. Look with me. Schizophrenia is due to high dopamine, and the Parkinson's is due to low dopamine. So in the treatment, the person that will treat it from schizophrenia maybe show decrease in the dopamine, which can cause Parkinson's. And the people that treated from Parkinson's and increase the dopamine, so can leading to some of symptoms of schizophrenia. So schizophrenia and the Parkinson's, when you're treating some people about schizophrenia, they can show some symptoms about Parkinson's. And the people that when you're giving them drugs for the treatment of Parkinson's, that can give a side effect of the schizophrenia or psychosis symptoms. About the Alzheimer, which is that decrease in the acetylcholine and oxidation of neurons leading to degradation of these neurons. Okay, that a change in the neuron and cause of the amyloidosis. That we will found that Alzheimer, guys, can be treated by given acetylcholine agonist, which is cholinergic agonist, and can give an antioxidant to stop the degradation of the neurons, like omega-3 and so on. So that's what I said now. It is the plan how to treat the disease. So what is the cause of the disease and how to treat them. What I will explaining after this, which is that about each disease, what happened on it, what are symptoms, what happen, and how to treating something like this and the drugs that used for these purposes. Let's start with insomnia, guys. So what about the insomnia? Insomnia, we can treating this type of disease at which the person can't sleeping well at all. We can using non-pharmacological treatment, which is like that exercise, acupuncture, yoga. We can using any of them to help in the treatment, but it's not pharmacologically. non-pharmacological. But about pharmacological treatment, like that OTC herbal medicine, like valerian root, like chamomile, like hops, lemon balm. And about drugs, we should to give drugs like antihistaminics, like diphenhydramine, doxylamine, and what we explained before. If you remember that we said that antihistaminic has a first generation has the sedation side effect. So this is why we're using antihistaminic for this, because it is decreasing the histamine in the brain, which can leading to sedation. Okay, but the second generation, it was has low side effect of sedation. The antihistaminic second generation has low sedation, so this is why we should to given first generation more than second generation in case of the insomnia. And about antidepressant like amitriptyline, doxepin, trazodone, okay, and about benzodiazepines like estazolam, triazolam, flurazepam, clozapam, temazepam, non-benzodiazepine GABA drugs like zolpidem and zaleplon. Zolpidem and zaleplon. They are have a GABA agonist effect, but they are not a benzodiazepine in their structure. So we call them as a non-benzodiazepine GABA agonist. And about melatonin agonist, like that, nowadays in the market there is OTC drugs for the insomnia. These OTC drugs is some about melatonin preparations like ramilitone and egomelatine, ramilitone and egomelatine, that can be used as a melatonin agonist to increase the circadian cycle, which is that the cycle of that wake up sleeping during the day, that you're sleeping at the night and woke up at the morning, early morning. If you have a problem about this, so we can using melatonin agonist that helping in that shifting the circadian cycle to the normal, not abnormal. A second disease, which is that anxiety. When someone have an anxiety, we should to give anxiolytic drugs. Okay, and in the anxiety there is million type of anxiety can be classified as an anxiety, like that an anxiety due to pain sensation. So sometimes we give an anxiolytics for pain reliefment. Why? Because anxiolytics can help in the treatment of the pain. Why? Because pain always accompanied by an anxiety. So if you're given pain analgesic plus an anxiolytic drug, this is will be very efficient to treat the pain. Okay. Other thing which is accompanied by an anxiety is obsessive compulsive disorder. Obsessive compulsive disorder, okay, which is OCD, obsessive compulsive disorder, which is that a person like that. Sometimes you found a person that is very, very, very critical to wash everything before use, like that, wash um, the bottle of a water before using it, wash his hands after he began to shake the hand, or the person after kissing, he don't try to kiss someone, and after kissing he try to wash his mouth and so on. These people have a type of obsessive compulsive disorder. Some others that is major obsessive compulsive disorder, that feeling that they are monitored by many people around them. Okay, and sometimes they feeling about that there is a problem about this, that all people around me try to killing me, try to um, make many problems for me, and so on. So in the obsessive compulsive disorder, this is major anxiety. So when we treating, we given an anxiolytic drug to decrease this anxiety that caused the obsessive compulsive disorder. And the other anxiety come from the phobia. Person that is have a phobia from water, hydrophobia. Person that have a phobia from high buildings, the hyophobia. People that have a phobia from darkness, okay, dark phobia. That all of these phobia is always accompanied by anxiety. If you're trying to let the person going up to the level, for example, the floor, for example, 18, for example, and let him watch from the balcony, at the same moment you will find that he get a panic attack or something like this due to the anxiety that he suffer from because he have a high phobia. Okay, at this moment these people we can treating the phobia by giving anxiolytic drugs. Okay, and also the panic attack is an anxiety. Okay, so what are anxiolytic drugs? Like benzodiazepine drugs, like the GABA drugs, benzodiazepines as diazepam, lorazepam, alprazolam, the family of zepam and zolam. And about the antidepressant like imipramine, paroxetine, fluoxetine, and so on. Serotonergic agonists like buspirone, and the beta blockers like propranolol. These are the anxiolytic drugs. Benzodiazepine drugs and the GABA drugs, gabapentin, zolpidem, zolpidem, antidepressant like that, imipramine, paroxetine, fluoxetine, serotonergic agonists like the buspirone, beta blockers like the propranolol. Now about epilepsy. Epilepsy. Epilepsy is a neurological condition which affects the nervous system and is known as seizures. Seizures, okay? And it's abnormal neuronal pulse that increase in the calcium and the sodium influx. So this is increasing the depolarization of the brain membrane, and this is leading to partial seizure or maybe generalized seizures. Okay, so if we say about these epilepsy or seizures, okay, we can found that partial seizures and generalized seizures. What about the partial and generalized? If if the depolarization occur in a very small part, okay, in the brain, and this is leading to ectopic foci of impulse. At this moment, this is leading to partial seizures or partial epilepsy. And about that, if this increasing in the calcium and increasing in the sodium influx, this is leading to depolarization in the whole cells of the brain. At this moment, this is called generalized seizures. Okay, so major types of epilepsy are partial and generalized seizures. Okay, let's talk about them, which is that the epilepsy, I can treating the general, I can treating the partial. But before we talking about how to treat this, let's given the types of general seizures and partial seizures and so on. If we look at the partial seizures, that the simple partial seizures like that the person will be aware, okay, and jerking happen, muscle rigidity, sensual and psychological disturbances, which means that the person with a simple partial seizures or simple partial epilepsy will suffer from that he have jerks or muscle rigidity, but he's still aware, and he have like that some psychological disturbance and sensual disturbance. But about the complex partial seizures, the person will be have impairment of awareness. Person will be unconscious, will be unaware. Okay, and this is leading to this problem. It's still that have a jerking, muscle rigidity, sensual and psychological disturbance, but the difference between the complex and the simple partial seizures, that the simple partial seizures, the person is still aware, but the complex seizures, the person get unawareness, impairment in the awareness. About the generalized, we have we have many types, like that the absent seizures, which is that the petit mal have a brief loss of consciousness. The person just like that, he had a brief loss of conscious and back again after moments or after about minutes. And myoclonic, which is that the sporadic jerking movement. But about that sporadic jerking movement, which is myoclonic, that myo come from muscles. Okay, so the muscle jerking happen, but it is sporadic. Atonic, which has no tone, which has a loss of muscle tone. And the tonic, which means that the muscle has a stiffness and rigidity. The clonic, which means that repetitive rhythm or jerking. Tonic clonic seizures, which can be called grand mal, that is unconscious, and at the same moment there is a convulsion and the muscle rigidity. How to treating epilepsy? By giving something decrease the calcium and sodium influx, which is decrease the depolarization. So I can give sodium channel blockers and calcium channel blockers. Sodium channel blockers like phenytoin, lamotrigine, carbamazepine. And about the calcium channel blockers like that etoxamide and valproate. Etoxamide and valproate. And there are other drugs that can be used as a GABA action inducer, that induce the GABA action, like the gabapentin, like the benzodiazepines as zibam and zulams, the barbiturates, barbitone and barbital. And there is a mixed action which has effect on the depolarization and effect on the increasing of the GABA action, like the topiramate, like the vijabatine, and the tiagepine, vijabatine, and topiramate. If we look, we will find the broad spectrum antiepileptics like the carbamazepine, valproate, lamotrigine, topiramate, vigabatine, phenobarbital, gabapentin, tiagepine, and about the drugs for treatment of absent seizures like that the calcium channel blockers, etoxamide and valproate. Etoxamide and valproate can be used for the absent seizures. And about the treatment of the status epilepticus, that given lorazepam, diazepam, phenytoin, propofol, tibental, all of these can be used for the treatment of the status epilepticus. And let's say that something about the propofol, tibental, both of them can be used as for anesthesia. Okay, can be used for anesthesia. And let's say that one question in exam before about the propofol, that if you given a patient a propofol, okay, with a dose, for example, 5 ml. Okay, and after this, you try to preparing the TPN for the patient. TPN, which is the total parenteral nutrition. Total parenteral nutrition, which is that after any surgery or anything, that the doctor didn't let the patient to eat, but he began to give him intravenous infusion. These intravenous infusion that contain many nutritions for his body. We call this the nutritions inside. We call this as TPN, or the total parenteral nutrition. The propofol is I just said that the person or administer propofol for anesthesia, it's about 5 ml. And you should to calculate the TBN for this patient. So at this moment, let's say at this moment that you should to increase the carbohydrate, decrease the carbohydrate, increase the lipid, decrease the lipid amount. I should to decrease the lipid that given as a TBN. Why? Because propofol is a lipid emulsion. So because it's lipid emulsion, this means that he will get a benefit of the lipid as a calories in his body from the propofol preparation. So if I give a vial of propofol to a person, this is let the person get the lipids inside as a calories. So I will not calculate the calories of the lipid, or I will put this the whole lipid calories. No, because some of them taken before in the propofol injection. So at this moment, we should to decrease the level of lipids, because the propofol is lipid emulsion. So I should to decrease the lipid amount that should be given to the patient as a TPN. Okay, let's guys to talk about the depression now. Okay, about depression, guys, the presence of at least 5 of the following symptoms during consecutive 2 weeks, you can consider this as a patient of depression. Like that: agitation, restlessness, and irritability, dramatic change in appetite, often with weight loss or gain, extreme difficulty in thinking and concentration, fatigue and lack of energy, feeling of hopelessness and helplessness, and the feeling of worthlessness, self hate, and inappropriate guilt, withdrawal from usual activity and society, and loss of pleasure and interest. Something that you can say this person is become like unsocial, non-social person. This person become like that, lazy person, always don't have energy to use it, and not doing the daily works that he used to do. And there is some of thoughts of death or suicide, and trouble in sleeping or excessive sleeping. Some people, uh, when they get some of depression, they begin to going to sleeping too much, and some others suffering from sleeping and have insomnia. Psychotic symptom like delusions and hallucination. And if we need to classify the depression to the major type of depression, there is a unipolar depression, which maybe is a major depression disorder, maybe dysthymia, depression disorder not otherwise specified like a dysthymia or a major depression disorder, and the bipolar depression, which that the bipolar type 1 or bipolar type 2, which is combined by attack of mania. Okay, which is that the person with a depression or the patient of depression sometimes have attack of or episodes of mania. 1 or 2 episodes of mania, often combined by depression episodes, is bipolar type 1. But if we're talking about that hypomania, which is not huge mania, not high mania, no, it is hypomania, hypomanic attack or hypomanic episode. Um, one or more of hypomanic attack combined by the depression can be called the bipolar type 2. The cyclothymia and the mixed manic and major depression and so on can be called the mixed. So the bipolar depression is always contain manic attack beside the depression. Okay, but the unipolar, which is only a depression, there is no mania. If you look, guys, this is the um, norepinephrine released from the sympathetic nerve, and here is a serotonin released by serotonergic nerves or neurons. If we need to remember, if you remember, if you remember that we said that the depression is come from what? It's come from decrease or norepinephrine and decrease in the serotonin. So we need to give in something that increase the norepinephrine or act as an agonist for the norepinephrine, and other which is that increase the serotonin or act as a serotonergic 2 receptor agonist. So what are drugs that can doing this? I can give in tricyclic antidepressant. Tricyclic antidepressant. The tricyclic antidepressant inhibit the reuptake of norepinephrine and the serotonin. Both of them inhibit the reuptake of norepinephrine and the serotonin. So it is inhibit both of the norepinephrine and serotonin reuptake by the nerve. So still increase the norepinephrine and increase the serotonin at the same moment. Okay, and that is sometimes we say it have some problems. Why? Because, or we always say that this tricyclic antidepressant have a big problem about that increasing norepinephrine leading to some of anticholinergic side effects. Some of anticholinergic side effects that increasing the norepinephrine can leading to anticholinergic side effects, dry mouth, increasing of the blood pressure, and so on. So this is the problem of the tricyclic antidepressant, because it increase also, plus that increasing serotonin, it increase norepinephrine, and norepinephrine have an anticholinergic side effect. Okay, and at the same moment, MAO inhibitor, other type of drugs like that MAO inhibitors that inhibit the MAO, as we know that the MAO monoamine oxidase enzyme that metabolize the norepinephrine. If I inhibit the MAO, so this is leading to what? This is leading to increased norepinephrine. So how can I give these drugs? I can give MAO inhibitors that increase the norepinephrine, okay, and this is given treatment for the depression, but still have the anticholinergic side effect like the tricyclic antidepressant. So I can say tricyclic antidepressant and the MAO inhibitors, okay, can leading to that anticholinergic side effect and post-hypotension, postural hypotension, okay, as with the tachycardia, because this is leading to tachycardia due to that norepinephrine release, and this tachycardia can leading to a reflex in the hypertension to become hypotension. Let's say that the serotonin norepinephrine reuptake inhibitor, which is like that decreasing the reuptake of norepinephrine and serotonin also, like the tricyclic antidepressant. So, but this is less in the side effect than tricyclic antidepressant. The serotonin norepinephrine reuptake inhibitors is another type, is another category that have the same mechanism of action like tricyclic antidepressant, which is that decreasing the reuptake or inhibit the reuptake of the norepinephrine and serotonin. So we call this tricyclic antidepressant, and other categories that have the same mechanism called serotonin norepinephrine reuptake inhibitors, Okay, but the serotonin norepinephrine reuptake inhibitors has a lower side effect than the tricyclic antidepressant. Okay, and there is other which is better nowadays in the market that I given serotonin selective reuptake inhibitor. I stop serotonin only by serotonin selective reuptake inhibitor. No action on the norepinephrine, just on the serotonin that inhibit the reuptake of the serotonin, so increase the serotonin, not act on the norepinephrine. Okay, and that is very good because this is decreasing the side effect of the anticholinergic and tachycardia and so on. Okay. And there is some others like that, noradrenergic or non-adrenergic serotonin selective agonist, non-adrenergic serotonin selective agonist, which is atypical drugs that nowadays discovered for this, for the depression. Let's given examples for these drugs that I'm talking about. The tricyclic antidepressant drugs, like that, some of them are tertiary amine and the other is secondary amine. What's the importance of this? Because if I asked you which is more potent, for example, clomipramine, okay, or nortriptyline, you will say clomipramine. Why? Because potency, which means that the drug deliver at the site and give pharmacodynamically action better. Okay, and when I say tertiary amine, this is can pass through the blood-brain barrier easily, so it can reach to the site very quick and very fast and very effective than the secondary, because tertiary amine can pass through the blood-brain barrier easily than the secondary. So amitriptyline, amoxapine, clomipramine, doxepin, imipramine, all of these can be considered more potent than dyspyramine, maprotilene, nortriptyline, because they are secondary amine. And we said tricyclic antidepressant have anticholinergic side effect, okay, and have a tachycardic effect. Serotonergic norepinephrine reuptake inhibitors that look like the tricyclic antidepressant in the mechanism of action, which is SNRI, okay, which have the same mechanism of action that inhibits the reuptake of norepinephrine and serotonin, like venlafaxine, desvenlafaxine, and duloxetine. Okay, and it has the same side effect, which is that anticholinergic side effect and so on. MAO inhibitors like that phenylazine trinylcypromine, and there is serotonergic selective reuptake inhibitors, which is SSRIs, and this is the most common nowadays in the market and most have a high market share, like sertraline, fluoxetine, paroxetine, citalopram, escitalopram. Sertraline, fluoxetine, paroxetine, citalopram, escitalopram. And there is, and the most common in the market, fluoxetine, okay, and it is fluoxetine is the most safe in the pregnancy, A typical antidepressant like the bupropion, trazodone, metrazepine, and these atypical antidepressants that we call them as a noradrenergic serotonin selective agonist. Non-adrenergic serotonin selective agonist. That is the most common in the market nowadays, or the most updated, or the most new drugs for the depression nowadays: bupropion, trazodone, metrazepine. Okay, because they have lower side effect, guys, because they act as an agonist, serotonergic, not adrenergic. Okay, Let's say that the mood stabilizer, this is one of the most important, which is like lithium. Lithium is a mood stabilizer. The lithium is used for the major depression, and in case of the bipolar manic depression. Bipolar manic depression. Why? Because it has a mood stabilizer that can adjust the mood. Okay, adjust the mood, not manic, not depression. Okay, and its side effect just that it can lead to renal failure, and this is a fatal side effect, very bad side effect. So lithium should be given hospitalized. Okay, should be given hospitalized and monitor the kidney function during giving lithium, because you know guys that lithium in the same column in the periodic table was the potassium and sodium, and the renal tubule have a competition in the potassium sodium excretion and reabsorption. So now we adding another uh, uh, additional element, which is lithium, that can competing with the sodium and potassium in the excretion, and that is make the renal tubule lose its major function, and this is leading to the renal failure at this moment. Let's talk about after this about the schizophrenia, which is about psychosis. Schizophrenia, psychosis. It's a mental disorder often characterized by abnormal social behavior and failure to recognize what is real. Okay? And the symptoms have a two type of symptoms, positive symptoms and negative symptoms. Positive symptoms always is something that reflect increase in the presence of abnormal behavior, like that hallucination, delusion, thought disorders, movement disorders, hallucination, delusions, thought disorders, and movement disorders. These are mainly about the behavior. He have in the behavior hallucination, delusion, and so on. But the negative symptoms that we can found this person after years or months have this of the beginning of the positive, he began to give the other, which is the negative symptoms, which is that loss of interest to everyday activity, appearing to lack emotion if you're talking with him and tell him and you and use about his family, for example, that your father has died. He began to laugh, he began to smile, he began to not crying. What happened? Because he lack of emotion, he can't decide what is this. Is that he should to laugh or he should to smile? What should he do? So he have to he at this moment he have lack in the emotion and reduce ability to plan or carry out activities. He don't know what he should to do. What's his plan? Neglect of personal hygiene. You can found him didn't go to washing his hands, make toothbrush, make anything of this. He lack of hygiene, and the social withdrawal. He don't have friends now. He don't have anything. He withdraw from the whole society. Loss of motivation. He don't have a motive to live for it. So some people in the schizophrenia going for suicide, like that depression also the people going to suicide. Why? Because of the motivation. When in the depression, when you have hopelessness and helplessness, so why you living? He begin to think about suicide. And here in schizophrenia, if you don't have any motivation, so why you live? So at this moment, these people can be going through suicide. And there is other symptoms, which is cognitive symptoms, at which that the most disability in the for psychosis because the interference with ability to perform routine daily tasks, like that problem of making sense of information. He don't know the information that you give to him, what's this meaning and what's the sense of them, and difficulty paying attention when you tell him something very very critical. He'll leave you and go. Why? Because he don't have a good attention. Okay, and memory problems. He can't remember many things in his life. So why schizophrenia occur in the brain? Due to that imbalance in the brain about the dopamine dopamine neurotransmitter. So we can found that the genetic factor and dopamine imbalance are the major causes of schizophrenia. And in the nigrostriatum, the increasing in the dopaminergic transmission in mesolimbic projection, okay, first to appear the positive symptoms, which is that behavior, emotional, and so on. So, firstly, at the beginning, the dopamine increase in the nigrostriatum. So this is giving the positive symptoms, hallucination, delusions, and so on. After this, by about months or years, the dopamine begin to decrease, and this is leading to in the mesocortical project, and this is leading to the negative symptoms, which is about thinking, about decision making, and so on. So this is why we classify them to positive and negative, because positive at which is that the dopamine increase and leading to the behavioral problems, and the negative because that the dopamine decreased and leading to this decision making problems, thinking problems, and so on, which is negative symptoms. The drugs that given to the schizophrenia called antischizophrenic or called antipsychotics or called neuroleptics, all of these are the same name for the drugs for schizophrenia. I can give drugs in the past that we given drugs that we call them now as a first generation antipsychotics, which is typical antipsychotics that mainly is dopaminergic blockers, and that is not that a good effect and has more side effect. Okay, which is that the like dopaminergic blocker like chlorpromazine, fluphenazine, haloperidol, mesoridazine, prefenazine, prefenazine, and thioridazine, trifluoroperazine. These drugs are called the dopaminergic blockers, are called the typical or the first generation antipsychotics, and has a higher side effect, which is weight gain, cholinergic action, and sedation. Cholinergic effect and sedation. Okay? And let's say that, in the other hand, the less side effect nowadays and more effective and more potent is that the second generation antipsychotics, which is atypical antipsychotics, like that serotonergic 2A agonist and dopaminergic blocker, serotonergic 2A and dopaminergic blocker that act as a blocker for both of them, like clozapine, which is most common in the market, olanzapine, quetiapine, azanapine, solibride, aripiprazole, melpredone, risperidone. The family of zapine, okay, is that like that zapine, like clozapine, olanzapine, quetiapine, azanapine, and so on, solibride, and so on. These can be called as atypical antipsychotics that decreasing the effect of the dopamine and serotonin on the receptor, because it is a receptor blocker for the dopaminergic and serotonergic 2A. They act by the way that called hit and run theory. that the most important about this, why the second generation is less side effect than the first generation, despite that it still make dopaminergic blocker. So in both it's dopaminergic blocker. So why this is second generation is less side effect than the first? Because the theory at which the mechanism occur is hit and run. Hit and run, which is that uh, um, like this, that the hit and run theory shows that the blocker go and begin to fit into the receptor. After this, dissociate from the receptor, and then back to block the receptor, then back to dissociate from the receptor. So we say that it hit the receptor by blocking it, then run from the receptor and dissociate from it. That is all the time occurring like this, not like that it is still in the receptor blocking it for longer time. No, it block, then after minutes it run, then block, then run, then block, then run. This is not give the major side effect or the higher side effect like that you block for longer time. If you block for longer time, this is can make the side effect is higher. Okay, let's talking about the Parkinson's disease. Parkinson's disease. Okay, guys. So about the Parkinsonism, let's say that it's imbalance in the extrapyramidal system in the brain. There is an area in the brain called the extrapyramidal system at the corpus striatum, okay, at which there is a balance between the acetylcholine and dopamine in the extrapyramidal system in the brain at the corpus striatum. There is a balance between acetylcholine and the dopamine, and this balance can make the person moving very well, that have a rhythm in the moving. Okay, like that you're moving your right hand with your left leg, and your right leg with the left hand, and so on. That is the normal movement, and you have a balance in the movement. But if there is imbalance in this extrapyramidal system neurotransmitter, that the dopamine is decreased due to dopaminergic neurons degradation, and the acetylcholine increased. This is leading to the imbalance, that low dopamine and high acetylcholine, leading to the disease Parkinsonism. And from the name of Parkinsonism, I can tell you what are symptoms of Parkinsonism. P, we can say paralysis, agitans. Paralysis, agitans. And A is akathisia. Akathisia. Okay, akathisia. It's look like the stiffness. It's that slow movement. Okay, and R is rigidity. Rigidity. And IN is involuntary tremors. Involuntary tremors. K is hyperkinesia or high in kinesia. And S for shaking palsy. Shaking palsy. And M is for masked face. So Parkinsonism, I can say Parkinsonism from the name we can deduce the symptoms. P for paralysis agitans. A is for akathisia. R is for rigidity. K is for hyperkinesia. IN for involuntary tremors. S for shaking palsy. Shaking palsy. And M is masked face. That is the symptoms of the persons that have Parkinsonism. And let's say that treatment of Parkinsonism, we need to increase the dopamine and decrease the acetylcholine. So we can using anticholinergic like benzotropine, piperidine, trihexyphenidyl. These drugs can used as an anticholinergic to decrease the acetylcholine. And there is a dopaminergic active drugs that increase dopamine, like the dopaminergic precursor. We know that the dopamine come from the L-DOPA, L-DOPA, levodopa. Okay. So nowadays in the market, the levodopa present with a combination with the carbidopa under the brand name Senmet. Okay, and it's the prototype, the first drug that discovered for Parkinsonism. What is the importance of carbidopa? The L-dopa, when you give an L-dopa, it should go through the brain, okay, and it is a precursor for dopamine. So I need, when I inject or I give L-dopa to the person, it goes through the blood to the brain, and from in the brain it will convert it to the dopamine, so increase the dopamine. But what happened, that L-dopa is metabolized by the decarboxylase enzyme in the blood. So we need something that saving L-dopa as it is not metabolized till it reach to the brain. So what is this drug? The carbidopa. Carbidopa inhibit the metabolism of L-dopa by inhibit the decarboxylase enzyme in the blood. So the carbidopa is decarboxylase enzyme inhibitor in the blood. So it prevents the metabolism of L-dopa till it reach to the brain and give the dopamine inside the brain. Other drugs that increase the dopaminergic action is dopaminergic agonist, like epomorphin, bromocriptine, carbidoline, pergolide, pramipixole, and ropinirole. Let's remember that the bromocriptine, we used it before in the treatment of the acromegaly and the gigantism or giantism, which is increase in the growth hormone. And also we used it for the people that has hyperprolactinemia, because that increasing in the prolactin can be treated by increasing the dopamine. As we said, the dopamine is inversely proportion with the growth hormone and the prolactin hormone. About the COMET enzyme inhibitor, that we can inhibit the COMET enzyme that metabolize the dopamine. So I can give COMET inhibitors like entacapone and tolcapone. Entacapone, the family of capone. Okay, the entacapone and tolcapone. And MAO inhibitors like siliglene. Okay, and there is NMDA receptor blocker action that have, like amantadine, have an effect in the Parkinson's, and it's not unknown the mechanism of action in details, or a detailed mechanism of action, but the amantadine is in the method D aspartate A receptor blocker that used for the Parkinson's disease. Let's before I go into the next disease, let's say something is very important. If you look, guys, you will find what? You will find that the schizophrenia, Parkinsonism, here it's the nigrostriatum, and here is corpus striatum, especially in the extra pyramidal system. Okay, we will find what? Look with me, guys, that in the schizophrenia, okay, the abnormal, that the dopamine is high, has high dopamine, and in the Parkinsonism the dopamine is low. So let's say that when I need to treat in the treatment, we should to give what? Dopaminergic blockers. Okay, and here in the treatment we should to give dopaminergic agonist. Okay, so all people that treated from in the treatment of the Parkinsonism, they will show as a side effect of schizophrenic behavior, which means that drugs used for treatment of Parkinson's will increase the dopamine, and increasing dopamine will help in the treatment of Parkinson's, but the increase in dopamine also will maybe leading to the symptoms of schizophrenia. So people that treated in the treatment of Parkinson's, okay, these drugs have a side effect of schizophrenic symptoms. And the opposite, when you treating the schizophrenia by giving dopaminergic blocker, you will find that it will decrease the dopamine to treat the schizophrenia. And this decrease in the dopamine can leading to Parkinson's symptoms. So in the treatment of schizophrenia, these drugs of the treatment can give a side effect of Parkinson's symptoms, like some of tremors, agitation, involuntary movement, akathisia, dyskinesia, all of these, paresthesia, and so on, which is that problems of Parkinson's. That's very important. The last disease in the central nervous system is Alzheimer. And in the Alzheimer, guys, let's just say that there is, in the brain, there's clumps of protein, amyloid plaque, and the tau tangles grow in brain. And protein standards twist, damaging brain cells, neurons. And the brain cells die, certain area of brain shrink. And this is most common with people over age the 65, okay, has a higher risk, but it can affecting the youngers. Look with me, that's what I will explain now, which present in the previous slide. That if we imagine this is the brain, this is the normal brain, this is the normal brain, as you see like this, that's the normal brain. That's the normal brain. Okay, if you look, okay, the normal brain contain the protein of the normal brain is always as a fluid protein, the protein which has some fluidity. Due to what? Due to it's in alpha helix shape, in the alpha helix shape of protein. When some of minerals, toxic traces, oxidative components, smoking, many things during our life that accumulate in our body, these minerals and bad minerals, some toxic traces, and so on, can induce the changing of the shape of protein from the alpha helix structure, which has a fluidic protein, to harder protein, which is a beta sheet, from alpha helix structure to beta sheet structure. Alpha helix is characterized by its fluid, but the beta sheet is more harder protein, that we call it as amyloid protein. So the protein, when it changed from alpha helix to beta sheet, or from the more fluid to more harder protein, that's called amyloid protein. And this is leading to what? Leading that these curvatures in the brain begin to be more deeper. Look with me, that if you look, it more deeper. These are, instead of this just like curvature, it's a tangle, is an entangle, okay, which we call it as tau tangles. tau tangents. So it begin to be more deeper like this. And let's show this in other color like this. And so on. So this leading to what? This leading to shrinkage of the brain, and this shrinkage is accompanied by the damage of neurons at this area. At this moment, guys, you can see what you can see. The brain now is become smaller brain, that all of this will disappear, is will damage it. The brain now will be like this. Not like the previous. So now the brain will be like this, and that is due to the amyloid protein production, and this is leading to tau tangles. These tangles is tau tangles, and this is leading to loss of many neurons and damage of many neurons. So it's leading to loss of memory. Loss of memory. Okay, so it's loss of memory. It's the major symptom, but which is dementia. Okay, but it's not the only thing. Okay, because this person will suffer many other things like that. Memory loss is the major, but also is unable to do normal tasks like cooking, dressing. Some lose ability to take care of themselves, unable to recognize relatives, friends, irritation, wandering off, and at the end he get depression. All people around him, he don't know them, he can't remember them. So that's make a depression. So in the treatment, we can give some drugs that use for treatment of the depression for these people. Okay, and if you look at the person that is in Alzheimer, you found that this person look like the baby, can't care for himself, can't or has inability to do the normal things, which is like that, cooking, dressing, cleaning, anything like this. And in the treatment, we should to do what? Due to the major neurons that damaged is cholinergic, so we should to give cholinesterase inhibitors to increase the level of the acetylcholine in the brain, like using of the drugs like tacrin, donepezil, rivastigmine, galantamine, physostigmine, and in the method the aspartate receptor blocker, the memantine, okay, and some adjuvant therapy like that antidepressant due to the depression that he will suffer from, like serotonin selective reuptake inhibitor or noradrenergic serotonin agonist. And there is risperidone, olanzapine, quetiapine for the behavioral symptoms, to treating the behavioral symptoms. Okay, guys, what we given is the whole diseases of the central nervous system and how to treating them. But now I will talk about the major structure of the medicinal chemistry, or the medicinal chemistry of the central nervous system, which one of the most important is the benzodiazepine. Benzodiazepine has this nucleus, which is that we have a 7-membered ring attached with a 6-membered ring, fused with it, and attached with a aromatic ring, as you see. That is the diaz, and this is a benzo. So benzodiazepine, okay, this is benzo, and this is diaz, which means 2 nitrogen. Okay, so this is the benzodiazepine. Okay, and let's say that long-acting benzodiazepine like diazepam, nitrazepam, flurazepam, and the intermediate like chlorodiazepoxide and oxazepam, short-acting like triazolam. Okay, that's the general structure. You should to remember it, because if you have any structure like this in the exam, you will you should to choose the benzodiazepine drug. And I said long-acting like diazepam, nitrazepam, flurazepam, intermediate like chlorodiazepoxide, oxazepam, short-acting like triazolam. About the barbiturate, which act on the same receptor, which is the benzodiazepine receptor, it contains what? Nitrogen, nitrogen, here is carbon, here oxygen, oxygen, oxygen as a carbonyl group, okay, and here is R1 and R2. If you have this structure in the exam, you should to say this is barbiturates. And long-acting barbiturates like barbital, phenobarbital, short-acting like secobarbital, intermediate like imobarbital, ultra-short like the thiopental, So it is long-acting barbital, phenobarbital, short-acting secobarbital, intermediate-acting imobarbital, ultra-short, which is very, very, very fast on onset of action, which is that thiopental. And about the antipsychotic drugs, which is that the phenothiazines, the typical antipsychotics, phenothiazines. Phenothiazines, if you look, it's contain this 6-membered ring, okay, which is that contain sulfur and nitrogen here in front of each other, okay, and here is a benzene ring with a halogen, and here a benzene ring like chlorpromazine and thyroidazine. And atypical antipsychotics, it look like this, it look like it, but it is 6-membered ring, 7-membered ring instead of 6-membered ring, 7-membered ring instead of the 6-membered ring, like clozapine and quetiapine and clozapine. Okay, tricyclic antidepressant, which is similar to the atypical antipsychotics, but the most characterized for this that the 7-membered ring maybe contain nitrogen or carbon, and at the same moment it is substituted here. It's substituted here in this area with a hydrocarbon chain here. Okay, and if we look that this is like the imipramine, dizipramine, amitriptyline or triptyline, and so on. Okay, guys. I finished for today, and inshallah the next will be about the cardiovascular lecture.